Good afternoon, everyone, and welcome to Grand Rounds. For you stragglers at the back, please come in. Thanks very much for coming. My name's Tom Farden. I'm the chair of Grand Rounds, and this week my friend and colleague Robin Smith asked me if he could have a slot to talk about what he's described as being a very dry subject, but I'm sure it won't be. I'm sure it's going to be very interesting, and what he's going to talk about is the Transforming Outpatients project, which he, as Associate Medical Director, has been leading on for a year, more than a year and a bit, I'm sure he'll tell us during the splurb, and how to improve our outpatient pathways across the whole of NHS Tayside, and there's a whole raft of different initiatives that he's going to talk about. He's brought some friends with him. Ross Jamieson is e-health manager, and Pascal Scanlan is the GP sub-representative and co-lead for the Transforming Outpatient Service. So, well, without any further ado, are you starting, Robin? Excellent. Robin Smith, spontaneous round of applause, Robin.
Thank you, Tom, and welcome everybody. It's quite a cosy group. Welcome, Perth. So, as you know, Tayside's found itself in a bit of bother lately. We've been in the news a lot, not always for good reasons. We've had a bit of financial issues. We have had some governance issues, both professional, clinical, financial, and we've been criticised for not really embracing a lot of the technological advances that there have been for delivering healthcare. And another thing is, we are quite a geographically large region. And where we deliver healthcare is not always optimal for the patient or always cost effective. So, as part of the response to all this external scrutiny from Scottish Government and so on, there's been a transformation programme set up which will take place over 3 years, and there are a number of different work streams. I'm glad to see our leader has just joined us, Peter Stonebridge. There's a work stream for unscheduled care, for mental health, for prescribing. What else? There's a missing one, and then we've got outpatients and elective care pathways. So, about 18 months ago, the Transforming Outpatient group was set up. And there's 3 of us here today, but we actually represent a much bigger group. I mean, we've got representation from clinicians, not just in secondary care, but across primary care and the partnerships. We've got HPs, we've got e-health, we have the business unit providing us with data, we have the head of medical records, because a lot of the efficiency and effectiveness of how we deliver healthcare is how we book patients and plan our outpatient clinics. Finance, we're playing into it, and we've got a lot of help also from the improvement team. Staff side also are an important group, because if you're going to change how people work, you need to engage the people who are delivering these standards. So, the context. A lot of what we do is elective and outpatient work. We get about 200,000 new patients a year, about 500,000 return patients in Tayside, and someone has calculated, I have no idea how they calculated this, but it costs £151 per outpatient episode on average. So it's a big chunk of how we spend healthcare money in Tayside. So we have a lot of challenges with this. The one that's really that Peter is under the cosh with, and our chief exec is meeting sort of national targets, seeing patients within 12-week target, meeting cancer weights. But we've also been asked to embrace realistic medicine principles, in particular shared decision-making, personalised approach, making it accessible, reducing variation in particular, and obviously addressing the economic aspects. But the important thing to say is that the transformation is not primarily driven by money, although some people in management think otherwise. It's primarily to make our services better, more deliver higher quality care, and by making them more efficient and effective, And then ultimately you will then get that benefit of financial benefit in the longer term. So Transformation is a 3-year programme, and we keep on getting challenged. Why have we not produced figures already? It's because it's a 3-year programme. It will take time for it to evolve and deliver. So the work that TOPS, Transforming Outpatients, does is kind of divided into 2 broad work streams. One of them is the effective and efficient, and the other is a pathway. I'll say a little bit about each of these. So within the effective and efficient bit, there is quite a few separate projects ongoing. So I'll go into some of these. I don't have time to go through them all, but I'll say a little bit about text reminders. ACRT is Advanced Clinical Referral Triage, enhanced triage basically, so spending time to triage when you receive a referral and getting better buck for the time that you deliver these services. I'll say a bit about more dynamic booking systems, and we'll hear later from Ross about a form of virtual consultations, in particular near me. And I'll also say a little bit about a referral management system, which we don't have up and running in Tayside. So this was a headline in the Courier about a year ago, in summer 2018, and basically somebody had obviously had phoned up, or I don't know if they were primed to write this, but basically missed appointments. So DNAs in clinics cost Tayside about $250,000 in 1 week. So when you have a dental appointment, or you have, I don't know, seeing your solicitor or something else, you'll often get a text reminder or an email to prompt you. We don't do this. Other parts of the country do this. So when TOPS was set up, we were looking for some low-hanging fruits, things that we could deliver quickly, and text reminding was one of them. We have a platform we could deliver that in, and in August 2018, we brought in text reminders. So before 2018, we were running about 12% DNA rate, and very quickly we brought that down by 3%. So the current rate, and that's been maintained up until now. So we're now running about 9% DNAs, and that's all due to text remindings. It's very easy to do. It's pretty reliable. Sometimes you have the wrong. You don't have an up-to-date mobile phone number for patients. We could measure the impact quite quickly, which is easy. We're grateful for this intervention, but other interventions is much harder to measure benefit. But we did have a few hiccups at the start, in that, for instance, some mental health appointments, the text reminder sort of reminded them to turn up at Murray Royal, when in fact it was a CPN going to visit them at home, so the patients became very confused. So that was quickly taken off. And we also had some governance issues around paediatrics, but so there's a paediatrician or two in the. So that's now happening in paediatrics, or about to, isn't it?
It is happening. The concerns about these older children, about the text messages.
Yeah. Okay. I'll say a little bit about enhanced vetting. So the traditional model with an outpatient is the referrer sends in a letter or a request for an appointment, and that gets appointed to a clinic. Patients get seen, tests get done, treatments get offered, or operations offered, or whatever. And that is the sort of traditional measure. But it's very inefficient. A lot of services across Tayside have started to do a bit of enhanced triage, and I know in respiratory we do that a bit, and there are some that have taken it to quite a high level. So what they do is they set aside dedicated time to spend vetting the referrals, and then they have options where they may organise some tests before they come. They may phone the patient, they may give advice back to the GP and cancel the referral, they may go straight to a procedure without the need to come to a clinic. All that takes time, and when everyone is pressured, the easy thing to do is just to press the button, appoint to clinic. But if you set your services up in a way that you can you're investing time to disinvest, if you like. And then the idea is that you will achieve this. So currently in Tayside we have demand is that top line, and our capacity to deliver for that demand is less than that. So that is why our waiting times have been going up and up. We've lost staff, we've refocused a lot of resource onto unscheduled care, which has taken away from elective care, and that has exacerbated the problem. So when other centres in Scotland have been faced with this issue in a more acute way, what they have done is they've basically cancelled clinics, ironically, and spent more time instead doing this ACRT process, and then the number of face-to-face appointments then comes down. So you then get down below the capacity, and you can then address waiting times. So it is quite a brave thing to set out to do, but you have to have faith, and you have to have thought it through, obviously, and you have to have access to tests and ways to do it. One of the things that really thwarts us is our track care, which doesn't allow you to hold an admission at present. So it means that when you open your referral on track, you either have to cancel it or appoint it, and it's not easy to hold it. And there's also a lot of things that, if you're jumping around requesting tests or looking at clinical portal, it's very clunky. So that is something that needs to be addressed, and there's work in progress around that. One of the things that one of the matrices that we get compared with the rest of Scotland is new to return ratios. So there's the business unit can give you personalised, can give you departmental or right down to GMC data on what your new to return ratios are. And if you go back a couple of years, we were pretty poor on that. It is getting better because there's been quite a lot of work in some specialties with discovery data and different ways of doing things that have already happened, but we're still a long way behind where we want to be. So our chief exec actually about 2 months ago said, right, the month of October we're going to focus on new to return. So we generated this sort of aid memoir. And the challenge statements on this is the review appointment necessary? Are you applying realistic medicine principles? Do you use a pathway checklist, which I'll come to in a minute? Have you embraced this concept of patient-initiated review? So rather than booking them, the patient only comes back if they feel they need to. And you can either use that by PIFU, what they call patient-initiated follow-up, which has a track code WWT, or you have an open appointment where the patient is actually discharged, but they still have the ability to come back within a year if they need to. So what a lot of services are doing is that they are giving patients a 12-month appointment just in case they need to be seen, and often that appointment is made, and by a year's time, if the patient's well, they often just don't show up, or they turn up at the clinic, you pat them on the back and let them away. It's a complete waste of resource. So if you use this, you can shave off a lot of your return appointments. An important thing is that if you do go down this route of patient-initiated review, you have to have a system in place that allows flexibility to accommodate review appointments at short notice. There's no point, if you're overbooked for months and months, then that defeats the whole purpose of having that system in place. So the next thing I'll just talk about briefly is about supported pathway work. So we've been working alongside lots of departments. Mine appears first, but in fact we're one of the smaller ones in this group, and we're probably performing not too badly, I'm pleased to say. But there are others in there, and some of you are in this room, and you will know that you are struggling for lots of reasons, whether it's understaffing of people being able to provide clinics, or it's because you've just been overwhelmed with the volumes, or it's because your systems are not effective and efficient to deal with that volume. So there's a lot of targeted work with the specialties and looking at individual pathways. I'm not going to say too much about how we do that, because I think Pascal's going to say a little bit more about that in a while, but there are certain principles that will need to be followed. We'll come to that. So here's just a few examples of some pathways that we've endorsed, and this is not comprehensive. I mean, there are about 10 rheumatology pathways that have gone through this process: carpal tunnel, shoulder impingement, celiac disease, the DVT pathway, and there's others that are in process. And there's the pre-assessment anaesthetic one is a real exciting one, where they've absolutely turned around and made huge amounts of savings in terms of staff time, and improved the patient experience in that as well. And likewise gynae, who have been struggling in the past, but they are really embraced a lot of the support that the TOPS team have been able to offer them. We were asked to create a pathway checklist, and it's quite a complex slide, and I hope most of you in this room will have seen this, but essentially it is a tool where you can analyze your clinical pathway, and you can use it both for quality improvement of the patient journey through that, but also you could potentially use it for performance review. So you need to look at ways that you can guide the referrer, so primary care, about what gets passed through, inform them, give them opportunities to do things like alternative routes rather than refer, social prescribing, etc. There's the vetting that I've been talking about, how you book. There's the various options for what you do when you get the referral and how you manage it. The opportunities to consider for virtual consultations, so virtual appointments by telephone, by Near Me, which Ross will talk about shortly. And then how you what the outcome from the clinic is, and what the different options that you have, which are most efficient and effective for that patient and for your pathway. What's happened here? Why is this not going down yet? So this was discussed and approved by the management team, the clinical directors had it, and the clinical leads, and it was meant to be disseminated. And we kind of assumed it had been, but we have recurrently come across struggling teams who have never seen it. So we thought it had been communicated, but it hasn't been. So I don't know if that is our fault or the fault of the system. We're now in a sort of system of we've moved to a management system which is clinically led, managerially supported, and we are moving into an era where clinicians are now empowered to make changes, and this is a tool to help you do that, rather than people just sitting back and expecting change to happen on their behalf. So when I say clinicians, it's not just doctors, it's nurses, it's HPs. So what have we done? What have we achieved so far? This is just a little few vignettes, really. We've had a 3% reduction in DNAs. We've had a big increase in advice-only referrals. We've turned on and track care for every specialty the option to give advice rather than appoint, because only some people were doing that. In August, we had this patient-focused booking, and we had 11,000 sort of patient-initiated review, so that's either patient-initiated follow-up or open appointments issued in August. There's a big increase in virtual appointments too. Unfortunately, we have not yet impacted on waiting times. It hasn't yet translated into financial savings, but I think we need to bear with us, and hopefully that will happen in due course. Now, I'll just very briefly, I don't know if you've all got your smartphones with you, but if you want to Google Ref Help Lothian, and I think I have what I could do is I could quickly give you a very brief overview. This is a system that Lothian have. So they basically have an internet platform which is open to the public as well as referrers, and it hosts all the clinical information pathways are here. I saw Elaine walked in. Is she still here? Or is she? Oh, you're there. I remember when we showed it to Elaine, I've never seen anybody get so excited about it. In fact, I should get you up on the platform. If I knew you were coming, I would have got you to do the demo. But basically, this is a Lothian one. You can pick any specialty. I'll just pick one of my own. So respiratory, and then initially you go straight to all the different clinical pathways within the respiratory pathway. So take interstitial lung disease, for instance. So here, if you can see what is available locally. It gives guidance of who to refer, who not to refer, and how to refer. And it tells you what needs to be done before you send off that referral. It is hugely useful, and the GPs and other referrers in Lothian love it, and secondary care love it too, because patient comes with a referral that is much better populated with the information you need to have to deal with that patient. And it also has resources and links, so it can show what the local guidance are, it gives you national guidance and so on. And this is designed for referrers, but patients are using it more and more. And their platform, it tells you the IP addresses of who has accessed it and where they come from. And this pathway has been looked at all over the world. It's incredible. They have huge traffic coming through it. So we want to have this here. We've had management approval to proceed with that. The key to it is having primary care time to host it, and interested GPs, ideally, who will sort of aggregate all the guidelines, vet them, make sure that they've had all the proper permissions and stakeholder involvement, and then publish them and have a two-year review of each one that's on there. A lot of the guidance the Tayside guidance that would go on that already exists. It's on StaffNet for a lot of people, or it's tucked away in very inaccessible areas that people can't access. In respiratory, we have it on an MCN network, which most primary care knows how to access, and Tom has been really instrumental at setting that up. But it's all in different parts. It's not easy to access. As you saw with RefHelp, I could get to the interstitial lung disease in 3 clicks. So it is very, very user-friendly, intuitive, and easy to use. So by April, hopefully, we will have the beginnings of one. And Ross has set up a platform that's ready to populate. We just need the proper governance and resource and the people to run it. So I've spoken long enough. Let's get back to the presentation, and I'll let Ross take over.
Hi there. For those of you that don't know me, I'm Ross Jamieson, Service Delivery Manager within eHealth, and I'm part of the Near Me programme under TOPS. I see some familiar faces who I've already engaged with around this programme, so apologies if I'm covering things you already know. So what is Near Me? It's virtual consultations using technology. In Tayside, we have branded it Near Me Tayside. It is using the Attend Anywhere software that's nationally provided through Scottish Government. The rationale behind us calling it Near Me Tayside is if we move to a new platform in 2 years' time, patients already know it as Near Me Tayside, so we don't want to have to rebrand again and confuse patients even more. Okay. So basically what it is, patients will come into a virtual clinic area online using a simple URL, which is www.nmt.scot.nhs.uk. They are then placed into a waiting area, and within that waiting area they are greeted by, we're calling them a virtual receptionist. They are real people, and what they do is they triage your patients. So they will check the demographics, they will check the patient's name, and ensuring that they are attending the appropriate clinic. So we have used case where a patient has epilepsy. They have hidden away in their workplace. They didn't want their employer to know that they had an appointment. They were able to connect on their mobile phone and have that consultation with the epilepsy service here without having to leave the workplace. So it's definitely beneficial from the patient's point of view. All patients with a near-me appointment type in track care will also receive a text reminder. And as you know, with smartphones, if you have a URL within your text message, you can click on it and you're instantly connected to that URL. So we're trying to make it as easy as possible for these patients to connect on the device that they have available to them. Okay, so key information. Clinicians can share their screen using this platform. So if you have results that you wish to share with a patient electronically, you can do that. Also, clinicians can invite others to join that consultation electronically, so you don't have to be in the same building to do that, and invite interpretation services if that's required within that consultation as well. The patient can invite their family members into that consultation as well, which can be useful. And they can take place anywhere. So we've had an instance where somebody's connected in their car using 4G on their mobile phone. So you can be anywhere with a device that has connectivity. 3G doesn't work very well, so we don't expect people to use it on 3G. 4G and Wi-Fi and wired connection works perfectly well. Okay, so this is just a little example. That's the patient information leaflet that will go out with the track care letter that is specific to a near-me appointment type. So no longer on the letter for that it will state your appointment takes place in Ninewells Hospital, because it doesn't. It states you have a video consultation using near-me, date, time, and that's simply it. That's a copy of the website. When you go to that URL along the top, that's what you hit as a patient. And it's simply that button at the bottom that they click on, and they're instantly placed in the waiting area for the virtual receptionist to pick that individual up. Okay, the journey so far since April of this year, we have the home antibiotic service live. They were actually the first service to go live using this. Epilepsy, they used to have a 40% DNA rate. That has reduced dramatically to around about 10% DNA rate for their clinic, simply because of the nature of these patients not being able to drive much of the time. They're coming into these clinics. Plastic surgery are using it, nutrition and dietetics. We've also enabled Perth Prison and Castle Huntly so that the inmates can then connect back to you as clinicians. As you're probably aware, it costs a lot of money for an inpatient, an inmate to come to an appointment here at Ninewells. So we've enabled there. Dalween Care Home in Aberfeldy has been enabled to allow the patients in that demographic area to come to a site to be assisted to use the product. We have child health HPs, dermatology, I see some of the colleagues in the room today, diabetes service as well, and area psychological therapies are all engaged and now starting to use this programme of work. There are other areas we're working with to enable in the coming weeks and months. So that's my last slide, you'll be glad to know. But that is the email address there. If you are an area that are not using this yet, have not engaged with us yet, please feel free to email us. And we will engage with you and come along to team meetings. We have equipment that we've ordered from tech funding, so we have cameras, we have headsets, we have microphones, we have spare monitors as well. Because what we do is we implement it, giving you guidance, support, training, etc. on the use of this, so you're not left alone using this tool. Okay. Questions? Or maybe you don't want that slide, but does anybody have any questions for me? Okay, thank you.
One question. People are setting up, are they doing it in their own offices, or is that generally where it's happening?
We are enabling the majority of outpatient areas with this within the clinicians' rooms, but we have had use cases. There was a conference recently, I don't know if you were there, Pascal, but it was the Attend Anywhere programme, and there was a consultant that did it from their home. And he took a picture of him in the upper part of his body where he had a shirt and tie on, and then he took a picture of his jammy bottoms as well to say this can be done anywhere. So I actually ran a full clinic from my home using a laptop. So,
Can I just add? The prisoner thing is it.
That's part of the guidance that's given to areas that are using it, as well as the patient as well. So the patients are reminded that this is a private consultation, and ensure that you've got the right lighting behind you so the clinician can see you properly. Also that you're in a private room. So if we are advocating you use it in the workplace, it's a private location at that workplace. So they are given that guidance around that. Nothing's recorded through this system, so as soon as you disconnect, there's nothing recorded and there's nothing that you can look back on. So all of that needs to be recorded and tracked here as normal as your consultation, so you can't use that at a later date. Okay. You want to add?
Just interestingly, I was sent to prison to check this stuff out. And I found out if you're looking after prisoners and you're getting a bit frustrated that they don't show up all the time, they're only told about an hour to 2 hours before they're due to leave the prison. Maybe lots of you already know this. And if they've got other things on, they might be seeing their lawyer, there might be just other stuff on, and they just go, well, I'm not going, knowing full well, it'll be rearranged. And that's your appointment gone. And they won't tell them earlier. It's a security thing. So the attend anywhere or the near me, is a very useful way out of that scenario. They just take them into a room and say, now you're on. Okay, any other questions on what we spoke about so far? You're all fully knowledgeable on these things. All right. Okay, I'll stick with the mic. Okay, well, look, a couple of things. I'm Pascal Scanlan. I'm a GP from Ireland. I came to Dundee about 25 years ago, sat in my room down in Tayside Medical Centre and just watched the world go by and watched the NHS disintegrate, went to meetings, told lots of people where the problems were and how they could fix it, and essentially nothing much happened. Joined the GP subcommittee to try and get a better voice, met previous CEOs, told them how to get things fixed, nothing happened. We had integrated care boards at one stage, surgical, medical, mental health and stuff, not a lot happened. And then everything went bang, and NHS Tayside was 40 million in debt, and general practice collapsed. So the last 18 months has produced a crisis, which the only good thing you could say comes out of a crisis is come at the crisis, come at the solutions. We are in a position where we can think outside the box, and we are in a position to actually say this is how things can be, and they can be different. And if you can find the final reserves within your departments or individually to put in the effort now, and then your legacy is going to be great for the generations ahead. So that's kind of what pulled me into this. I joined TOPS as a GP sub when they met every 2 months. It was a board then, and the idea was I would link in with all the pathway stuff. But then when Michelle Watts moved up to Edinburgh, I asked if I could join Robin on a weekly basis to try and drive all the other things forwards. TOPS, we have this stuff ready. We got stuck into this stuff and all these abbreviations, ACRT and PIR and PIFUs and so on. If you come to us, we have the ability to help you with things, but you guys come to us. Somebody contacted me recently and said, well, in an email, it effectively said, well, TOPS haven't been to us yet. That's not how it works. Okay, I can't go around to each department on a weekly basis to see how you're getting on. But if you come to us and engage with us, it's there. And we've had some great successes, and I thank all the people who did come and have worked with me, and Robin and Ross and the team and Jenny and the whole lot of them. It's a great group of people, and my loyalty is very much to that group. It is a unique scenario in 25 years I've ever seen where a bunch of people can work together to make a huge difference. So my enthusiasm for this is, I hope, coming across. All right, put on the other hat. I work for GP Sub, and GP Sub works for GPs. So sometimes I have to say how things are out there. But I've learned a lot seeing the life from your side of the fence. So I can bring to the table is how things are on our side of the fence. So Ref Help has been a major break. We're going to go down that path. In 6 months or a year, that's going to be there, okay? And what you want is to get all your stuff up onto it. And the pathway to get your stuff onto it is through TOPS. When you go out and think, you know what, this could be better, I can write this up, we can make this better, just come and talk to me so I can see to you don't run into a roadblock. One of the roadblocks you guys aren't aware of is the whole thing about what do GPs have to do and what are GPs encouraged to do. So a guideline is what we should be doing, all right? But I've been flooded with guidelines for years. That's not a problem. I have a book, I go to Hot Topics, how best to manage something. So all that's really useful. If you are coming up with guidelines on primary care management, it's not really GP sub is going to be your roadblock. We don't get really involved in that. But I've been asked by my colleagues who run the prescribing management group and people who are in charge of prescribing budgets to make sure you run it by them so that you don't go to all this trouble, have a beautiful document, and you've got a drug down there that is non-formulary in Tayside, and GPs won't prescribe. It might be available on the BNF, but it doesn't necessarily mean it's going to be a success. But when it comes to referral pathways, that's where GP sub comes in. Right? We're trying to make things flow and work well. But what you don't want to do is say, you're going to do this. My responsibility with my colleagues, I make no decisions by myself, by the way. I'm just the voice. It goes through other GPs on the GP sub, this way you guys have the consultant subcommittee. So we can only approve stuff that every GP can do, that all GPs can do across Tayside. So it might work really well for me in Dundee with my systems, and I've got 6-7 partners. But I have to make sure whatever we agree to must work for a 2-partner practice up in Blairgowrie, with 1 partner on maternity leave at the time, on a Friday afternoon when the locum's covering. It's these kind of scenarios we have to tease out and have backups and have a way of making things work. And 99% of the time we do. I mean, that's why we've had good interaction with rheumatology, ENT, gynae, and so on. And if I haven't mentioned you, sorry, but we've had a good run. But every so often we run into something that causes severe consternation. And I just don't want that to happen. I've been trying to say to people, come and meet, come and talk. All right, any questions? Yay! That's exactly the case. You don't have to reinvent the wheel. You don't have to sit down. And also, lots of this stuff is central. Okay, we didn't sit down in Tayside and come up with a lot of this stuff. So, Modernising Outpatients is the Scottish Government, and I was there yesterday in Edinburgh. That's better. And they have the Scottish Access Collaborative, which some of the departments here are majorly involved in, but some of the departments are very peripheral and have not been involved. But you can go online, print out what they have, and say, yeah, that'll do us. Get it to us, to me at TOPS. You're done and dusted for Christmas. That's my latest phrase. Done. It'll all be over by Christmas. Well, maybe. But the more, you don't have to sit down and work from scratch for hematuria, for vascular. Well, vascular are in trouble. No, you're not in trouble. There's a big vascular meeting coming up, because they're the last of the 12 groups to come up with a final document, but they're close. I mean, that's 12 major departments have come up with pathways. GI are in Stirling tomorrow. I won't be there. You'll be glad to hear.
Lothian, just to follow up that, Lothian have been involved in helping us set up here, and their stuff on there is publicly available. There's no copyright. Anybody can use it. It's just that what we put up has to fit in with what we can do locally. So there will be local variation, and that's why we need to have. It has to be hosted in primary care, who will then liaise with all the specialty teams to build whatever documents go onto there.
So, can I just ask a very practical question? Hang on, we can't hear you. Well, we're talking, can't hear you. So, I mean, probably it's entirely my fault for being ignorant, and apologies in advance. But this all sounds great, and I feel as though I've never heard of it all, and yet it's been going on for quite a while. So I'm sorry, Robin. But if we wanted to for the clinical group that we're working, I mean, how does it take place? I mean, if we come, how do we contact TOPS? How do we initiate discussions and get the ball rolling? And how does it work after that?
So the weekly huddle is at half one in the Improvement Academy. It says level 5, but you go up a flight to level 6. And half 1 to half 2, that's where we meet and we interact with everybody who needs it. So you just say, can I come such a Thursday at half 1? Join us, and we take it from there. It's as simple as that, really. Yeah.
Anybody else got any questions or comments? Oh, we can't hear you. Yeah.
Hi, it's just a comment. I work a lot with the north of Scotland and paediatric gastroenterology, so we're networks, and obviously they have been using the equivalent of near-me technology for a very long time. One of the things to really be aware of, apart from travelling time potentially for clinicians, this does not save, obviously, clinician time, and potentially does increase clinician time when there is the odd technical glitch with equipment. So as soon as you bring equipment in, it's just an awareness, and it does take a bit of teething time to get used to it. So you can't just treat it like a normal outpatient appointment immediately until you have, and the patients are familiar with the technology and how to use it.
Okay, we'll have a learning curve, yeah.
Although our time is important, their time is important too. Your average 20-minute outpatient appointment takes 2 hours of a patient's life. So it's we have to be mindful of that. No.
That's fine. We'll have a learning curve. A lot of this stuff has been a learning curve. Like, we've kicked off with certain things and then realised, like with the texting, that there are wee glitches on the way. So we'll see how it goes.
I just wanted to talk a little bit about people saying that RefHelp is there already in Lothian. In urology, what is on RefHelp in Lothian is incomplete and doesn't meet the current plans that are put in place by the Scottish Access Collaborative that we're engaged with. So what we're actually doing is engaging with them to make sure the national guideline is the one that we would have ready to put in place. I encourage people to go and look at RefHelp at their own specialty and have a look at what is actually there. Whilst there's something for every specialty, a lot of it's limited, and some of it's as much of a legacy as the things that we've been using here.
Can I just add, we've had 45 minutes here to just give you a taste for this, but any one of these topics we could have an hour talk on, and we could set out in more detail. Some people would say, I know about active clinical referral triage, ACR, we're doing that, okay? And the answer is, you're doing a version of it, but you're not actually doing it. Okay, it's worthy of going in more deeper. People today, the stuff is about how clunky track care is. Yeah, it's clunky. It's not great, but it does more than many people know. Because I spent time with Linda Fox, and she talked me through it. And I looked at the portal, we call it StaffNet tutorial pages, and read them. Okay, there's things that it can do that there are kind of hospital myths about. Well, you can't do that. I mean, GPs write into me and say, why didn't they do X, Y, or Z? And I contact the consultants, and they go, well, we were told I couldn't do that, or my friend told me I couldn't do that, and it can. So there's all along the way from every step of the process, there's more stuff to feed back to you to make things better, and they can get better. And for also, another area I'm working on, it's taking a bit longer, referral starts in the GP practice. When I get that, we need to turn off the tap. So only recently did I get vision of the access policy for 9 Wells, for Tayside. It's an amazing document that's been on the internet for a few years now, and practically nobody reads it. And it says on it, based on national guidelines, all the things the GPs are to do. You should tell a patient their responsibilities, tell the patient if they're going to go, where they're going to go for the service, and let them know if they're going now to Perth for urology or going to Clydebank for ortho or something. But no GPs have seen it. It's never arrived in my in-tray. It never went to GP sub in its current form as something that we can disperse. Some point is, if you've got good stuff and you want to get it out there, I can send it out. I mean, we can get it out so more people are aware of it. So it's not, just want you to know, it's not all about your side of the fence. You've got to do better. You've got to improve things. It's going to be on the other side as well. Okay? So just letting you know that.
Okay, I shall draw things to a close there. I'd like to thank our three speakers for coming to speak today, and thank you all for coming to listen to all that. And if you are interested in the improving outpatient pathway stuff, then speak to Robin or Pascal, and I'm sure they'll be happy to have you approach them by email or in person. Next week at Grand Rounds is a collaborative piece of work between infectious diseases, respiratory medicine and public health. We're going to talk about tuberculosis, the consumption. No? Shaking of the head from the back of the room? Never heard of it. We'll talk about diabetes eventually, Chris, don't worry. So TB next week. It's a smorgasbord of specialities. Thanks so much for coming. See you next week.